If you're facing a hip replacement and someone tells you the anterior approach recovers faster, it's fair to be skeptical. So here's the honest answers. Yes, it's faster, and the early weeks really are easier, but the destination is the same. And this is still a major operation that deserves your respect. Understand all of that completely, and it will change how you plan your recovery and how you talk to yourself when you compare your week 3 to somebody else's. I am Dr. Cory Calendine, an orthopedic surgeon in Franklin, Tennessee. I perform hip and knee replacement exclusively. This is my independent clinical perspective, and it's not a substitute for advice from your own surgeon. So, what actually makes the anterior approach recover faster? It comes down to how we reach the joint. The anterior approach, we go between two muscles of the front of the hip rather than detaching them. Your muscles are moved aside and not cut through. Because of that, the hip is very stable from the moment the surgery ends. And you can put your weight on it right away. The walker is there for your balance, not because the hip can't take the load. And there's really only one precaution I give you after anterior hip replacement. Avoid the extremes of motion, like putting your ankle behind your head. Patients love hearing that. They brace for a long list of rules and restrictions that simply never come. Let me put that in context because the contrast here matters. With the anterior approach, there are almost no restrictions. You can sleep however you want, sit however you want, and get back to your day really quickly. The only limitation is that one common sense limitation of avoiding the extremes of motion. That's different from the posterior approach, which reaches the hip from the back. Posterior is a good operation, and I use it myself for revision cases that need a wider, more open exposure. But it usually comes with those classic hip precautions early on. Depending on the surgery, that could mean 6 to 12 weeks of not bending more than 90 degrees, not sitting in low chairs, and not crossing one knee over the other knee. So why the difference? Overall, the research has shown lower dislocation rates with the anterior approach. And that's likely the reason why those early precautions can be essentially eliminated. And I'll be fair here because honesty is the whole point of the channel. When the posterior approach is done with modern techniques and with technology that improves how those components are positioned, its dislocation rates can come very close, if not equal, to the anterior approach. So this isn't approach worship. It's just why the early rule book looks different, so much different, if you have an anterior approach versus a posterior approach. So here's the physical therapy plan after. And it's simpler than you think. Walk, walk, walk. For most of my anterior hip patients, that's the core of it. I don't send everyone to formal physical therapy, although there are times for that. I do give my patients home exercises, which some of them do, and then I want you walking and gradually returning to your normal activity. Too much therapy early on can make the hip sore without really speeding anything up over time. Most patients don't need formal PT. Walking is the work. The milestone everyone asks about, though, is work. So when can I get back to work? It depends on what you do. So I want to give you a range here. Driving comes first. That's needed for a lot of jobs. And the rule is pretty straightforward here. You can drive once you're walking steady with a cane as long as you're off all the narcotics. So for desk work, that's often about 2 weeks. You can go back to work when you're driving. If your job puts you on a roof or if you're doing heavy labor, plan is closer to 6 to 8 weeks being back to work. I try not to pin down an exact day for any one person because every patient brings their own situation, but that range gives you an honest frame to plan around. Let me tell you about one patient because he captures something very true here. He's a physician. This was his second hip replacement. His first hip replaced maybe 3 months earlier. And at 6 weeks, he sends me a picture of him downhill skiing. Now, he was a trained, avid snow skier. So the lesson isn't everyone skis at 6 weeks. The lesson is that returning to an activity that your body already knows is genuinely achievable, and often sooner than you'd guess. But I still owe you the rest of the story. High demand activities carry their own unique risks, and they're different than just the hip itself. If you fall downhill skiing and break your thigh bone, that's the bone around your implant, you may need that hip replacement redone. That's not the hip failing you, but the hip won't hold you back, and you risk having to redo the hip replacement just based on the risk of that activity. So we individualize it. We individualize the risk of activity. We individualize the risk of returning back to your job. The goal here is giving you back the things you haven't done in years. That's the goal. And the power of hip replacement is restoring what your body already wants to do. So now the part I really want you to hear, and it's important. This is still a major procedure, and you should respect it, even though recovery is genuinely easier than people feel. Here's something I tell every patient. You're going to do very well no matter which approach your surgeon uses. The best approach for you is the one that the surgeon you trust does the most often and feels most comfortable doing. Every one of these techniques, anterior, posterior, all of them, they all have their own unique technical demands, and it takes real repetition to do them well. That's exactly why I've dedicated my entire practice to only hip and knee replacement. You might think that since I've done thousands, they all start looking the same. The opposite is true. The more hips I do, the more I see those small differences from one hip to the next, the nuances that actually matter. So being focused only on hip and knees, that's what makes me better at what I do. So when you choose a surgeon, you're not shopping for a brand name approach. You're looking for someone who does your operation often and does it well. And one more thing about your own thought process during recovery. There's a wide range of normal. So try to avoid the comparison trap. Your neighbor's hip is not your hip. Hip replacement across the board is easier to recover from the knee replacement for sure, but the anterior approach also helps in those early weeks. It makes them even smoother, but your journey is still yours. Some days will be better, some days will be worse, and that's totally normal. The thing I hear most once people are through it is the same sentence over and over. Why didn't I do this earlier? Recovery from an anterior hip is faster, the early weeks are easier, but the finish line is likely the same strong, stable hip you would reach no matter how it's done. A faster path to the same destination, and honestly, that's plenty. If you want to talk through your own hip, a link to schedule a consultation is in the description, but more importantly, I hope you'll come back here, we'll talk more. Thanks for watching.